I'm Frank Weinberg. I'm a thoracic oncologist here at University of Illinois Cancer Center. I have a PhD as well, and I do a little bit of translational research, as well as I run the thoracic program here at University of Illinois. So, a little background from me. I actually got my PhD first, and my PhD was actually at Northwestern University here in Chicago, with Dr. Navdeep Shandell, and we worked on sort of understanding metabolism and how it relates to lung cancer development in particular. And so that's always been kind of with me. And as I've gone through my training, and I did most of my training at University of Michigan, my residency and my fellowship, and I did research there that kind of started to try to understand sort of the interaction between the lung microbiome, metabolism, and host immunity. And so a lot of the research that I do now is kind of looking at patients with lung cancer or patients at high risk of developing lung cancer and trying to understand, are there immunometabolic biomarkers that we can discover that we could potentially, target therapeutically, or even, from a preventative strategy point of view in the future. And so that's, I have a little lab, a basic science lab here. And so we do mechanistic validation there, but a lot of my work is really translational and focused on patient biomarkers that we can kind of translate into better treatments. So initially, I mean, obviously COVID-19 impacted my training and whatnot because I was in the midst of my fellowship. And so that changed things, right? But how it changed how my research or my research focus, it got me thinking about vaccines and I think tumor immunology more in depth, right? So, the vaccines that were developed around COVID were mRNA vaccines. They had been around for a long time. And I started thinking, could vaccines, alter the immune landscape in a person to make them respond better to immunotherapy and things like that. So actually, initially, when I first got here, I did some research looking at patients with lung cancer who got the COVID vaccine to kind of try to understand whether or not those patients who got the vaccine, were there changes in their circulating immune biomarkers that maybe indicate they might respond better or worse to immunotherapy. So that data, we're still analyzing a lot of that data, but there's this whole area of cancer vaccines and therapeutics, and I think for me, at least, the COVID experience and then the COVID vaccination experience kind of opened my eyes to potentially, are there vaccines that we can implement into cancer treatment? Through my work at University of Michigan, we've identified what we think are like early biomarkers. So a lot of the patients that we studied at University of Michigan were actually all early stage patients with lung cancer. And so through the analysis of that, we found that there's some interesting lipid metabolites that we detected, a specific fatty acid called stearic acid. And we find also that there's an association with that stearic acid and macrophage markers, so markers of macrophage inflammation. And so here at the Cancer Center at University of Illinois, my lab kind of worked on the mechanistic validation of that data, and we actually have found, that at least in vitro, in cells, stearic acid can induce macrophages to kind of stimulate sort of the formation of tumors, at least in a dish. So, potentially that's an early marker, even maybe a preventative marker for tumor initiation. And so we're going to do more in vivo work, kind of in mouse models, to see, if our findings hold true. Yeah, so we already know in the lung cancer space, there are certain patients or individuals that are at high risk for developing lung cancer. Usually, these are patients who have a significant smoking history or are currently smoking, and then an age from 50 to 80. These are all patients that then are recommended to get yearly lung cancer screening with a low dose CT image. Those patients, in the United States, it's about 1% of those patients will go on to develop cancer. But here at University of Illinois at the Cancer Center, we have a really robust screening program. And in our population, which is about 70% African American, we see about 2.5% incidence. So that's more than double the national average of lung cancer detection here. So in the future, the hope is that early markers that potentially a lipid marker that we found, we could validate that in our population here, and potentially, is there some sort of lipid therapeutic that we could utilize as a preventative strategy, looking at the downstream immunity, how that is affected. Are there specific cytokines we could target with already, available products on the market that could potentially be a preventative strategy for patients who are at high risk for developing lung cancer? So, at least if we're talking about the high risk population, we're not yet really there where we have sort of a biomarker. We have clinical information that we're using to kind of say, hey, this person is at higher risk for developing cancer. But we're not really there, at least in the high risk population, to kind of say, hey, this circulating biomarker is something that, is relating to you going on and developing lung cancer, right? In the early stage setting, there are prognostic biomarkers, most of them genomic biomarkers, things like EGFR and things like KRAS. We know that all of these genomic alterations that are driver mutations in the cancer do have prognostic implications, and now oftentimes predictive implications as well, but that's more in the later stage setting. I think another thing that we're starting to see in terms of biomarker development is the ctDNA development, and we're starting to utilize that more and more in lung cancer. So the way that would look is, patients who go through treatment and then, have ctDNA that's positive even after treatment, especially in the early stage. Maybe those are the patients that you prioritize treatment for, as opposed to those patients who maybe have minimal ctDNA or maybe negative, don't express any or aren't detecting ctDNA in the blood. So we have biomarkers like that, but we don't yet really have preventative biomarkers. So that's a great question. I think, certainly understanding how all of these sort of different physiologic processes, whether it's the immune system, whether it's genomics, whether it's metabolism, whether it's epigenomics, how all of that kind of integrates, because it's all integrated. I think for a long time in the field, we've looked at each thing individually, right? There was a long time that we just focused on the genomics of the tumor, right? That was, basically when until really the mid 2000s to late 2000s, where we were still really focused on the tumor. But we now realize that, there's other factors. There's what kind of tumor immune cells are there? What does the immunity look like around the tumor? All of these things are now important. So the field is opening up. I think the struggle is, how do we understand each one of these biological processes as it relates to the others? So certainly there are epigenetic markers in lung cancer and other cancers that we know exist that help to drive the lung cancer. But how that actually relates to the upstream other processes, I think that's the key. Understanding how all of this is interrelated, that's going to be the way that we come up with the next set, better iterations of treatment for patients. I love that you bring that up because one of the things that you have to do with these large data sets that we're generating, and I talked about in our own research, it's immunologic data, it's microbiome data, it's metabolic data, right? How do you integrate all of that? We actually use machine learning to do this, right? We utilized a model in which we could kind of integrate these three data sets to pull out potential interactive pathways, right? So I think, and found one, right? Potentially that needs to be validated, but a potential pathway that, maybe is going to be something that will lead to therapeutic development, right, down the road. I think that that's the only way we have right now to understand all of this data together, right? We're really good at understanding one data set alone, but when we start integrating all the data sets together, I think our human capacity might not be there yet. And so machine modeling really comes into play. Neural networks come into play to understand how these things are interrelated. From other perspectives in medicine, I foresee, artificial intelligence being very important down the road, potentially for precision oncology, for us to try to understand what is the best way we should be treating lung cancer, for example. Lung cancer, I believe, has the most amount of molecular targets, right? And so we oftentimes will get, data back from genomic analysis, and we're like, what should we do with all of this, right? Is there a way we can incorporate artificial intelligence and machine learning into this, to potentially find better treatment options for patients and really practice precision oncology at a higher level? Absolutely, I see it being used and utilized. These large data sets are what we have, right? And so I think certainly utilization of those data sets with machine learning is invaluable. What I'll say, a caveat about these data sets are they're not controlled, right? These data sets, things can, are done in different ways. Techniques are different between data sets and whatnot. So, oftentimes to compare two data sets, two large data sets together, you run into issues there, right? But I think going forward, prospectively, as we do prospective studies, we should be thinking about standardizing the way that we develop the data, right? So that, our machine learning models don't necessarily have to have that, can have that error kind of at least better corrected for. I'm really, so one of the things that I've become passionate about since I started here is really clinical trial access. Um, I trained at a place, Michigan, much different patient population, right? But here, we're a very unique cancer center in the fact that we care for we're kind of community in a sense. We care for patients from the west and south sides of Chicago. But the problem with clinical trials, national clinical trials, are if you look at the demographic data, they don't represent the patients that we see every day. So I'm constantly having to extrapolate those results. And when we talk about precision oncology, I really can't say that I practice precision oncology per se. I do whatever, the guidelines say, but my patients are fundamentally, I have a different patient population than what most of those studies were all based on, right? And so one of the things we want to do here is start to understand our own patient population, right? And so that we can develop precision medicine for our specific patient population. And we've done a good job in bringing clinical trial access to our patients. Our lung cancer clinical trial program is robust. We have lots of studies. We've been able to, we have an enrollment rate that is about 70% of patients who have an actual clinical trial available to them will go on to study. And then that's about 60 to 70% Black patients. So, we're doing something right. And so a lot of what we do is kind of to bring access to patients. And I think through those sort of endeavors, we're going to start to develop, data that will come out that will be more representative, and we'll be able to better understand how to apply therapeutics to all patients, right? I think that you're hitting on something that's so fundamental. I think, you know, um, what we've done here is when I first started, we started collecting data on our clinical trial enrollment, and over the past 2 years, we're getting ready to actually publish this data. We have impressive enrollment rates, at least in the lung cancer um, program, right? And we wanted to understand why that is. And we actually did a study where we utilized surveys, and we gave surveys to patients to kind of understand why or why not they're enrolling in clinical trials. And it was interesting. I mean, in a sense, it wasn't surprising. The biggest thing that led to someone enrolling was trust in the physician. So I think, that's fundamental, and that's not something that you can necessarily teach. But I think through education, there needs to be better education initiatives, and whether that means providing education about what a clinical trial truly is. Um, I think, I haven't encountered a lot of mistrust because of the way that I think I present a clinical trial as not so much, you know, necessarily, we do have phase 1 studies, but it's not so much a new drug that nobody's ever used, or a mechanism that nobody's ever thought about. It's more that we have studies utilizing medications or similar medications to what's already being used, but just utilizing them in a different way. So that, I think it's a number of things that have led to our success. I think it's our ability to talk frankly and openly and establish that trust with the patient right up front. And then it's also the fact that, we're cognizant about the types of trials we're bringing in and the types of trials we're developing for patients. I think there's a whole feasibility and there's a whole logistics part of things, especially for my patients, that need to always be thought about. How often are they going to have to come for a follow-up, right? What are providing support. Many of my patients have socioeconomic factors that lead to them, for whatever reason, not being able to come, or not, just hardships, right? And being able to provide for those hardships is a huge thing that we can offer patients through clinical trials and through just them coming and being part of our cancer center, not necessarily through a clinical trial. I think the other aspect to clinical trials is traditionally where clinical trials have been done are not usually the academic centers that see a diverse patient population. And so to expect those centers to just all of a sudden be able to recruit a diverse patient population is probably not reasonable. And especially not reasonable if you don't put into practice an educational component for physicians as well as patients into what a clinical trial is. And understanding, what are the barriers to clinical trial and enrollment in different patient populations, right? And so hopefully some of our work that we're doing here will help other institutions kind of develop programs that will improve clinical trial enrollment for, underserved, underrepresented a population of patients. Oftentimes these patients will come into the hospital, right? They maybe don't follow very frequently with their primary care because they're younger patients. They don't oftentimes go as much, and then all of a sudden, their shortness of breath. They have, significant shortness of breath. Maybe it was seen by primary care and they gave them antibiotics and nothing happened. It got better, and their shortness of breath got worse, and now they're in the hospital and they have florid metastatic lung cancer. We see that those cases, unfortunately, we see those cases more than we'd like. But that's oftentimes, the younger folks oftentimes come through the hospital. We're diagnosing them in the hospital. I think, you know, certainly there are a couple different things, right? Clinical trial access, and making sure that they have access to cutting edge treatments, right? That's obviously, because that's where practice changing things come from. So that was one way to improve outcomes, right? Biomarker testing is a huge thing in lung cancer, right? And patients oftentimes don't have standard biomarker testing performed. We know based on the data, it's about 50 to 60% of patients with lung cancer that get biomarker testing alone. And then of that, looking to see how many actually get standard biomarker comprehensive molecular testing is even less, right? So there's a disconnect there in terms of understanding, there could be a potential therapeutic that you're not offering a patient that should really have that as first line. That, is huge and will improve outcomes if we can do a better job in biomarker testing across the board. So I think those are two areas in lung cancer specifically where we can work and improve, and I think we'll have ramifications on outcomes. So if we talk about lung cancer, it really should be something that's sent now on all cancers. If you look at ASCO guidelines and whatnot, they're saying, I think if it's two alterations or two or more genomic alterations, you should be sending, molecular testing. I mean, lung cancer now all the way up late stage as well as early stage, we have that, right? And so, I really advocate that all patients with lung cancer, a lung cancer diagnosis should get biomarker testing. What I hear a lot is people in the community, especially, concerned about insurance coverage. Now, at UIC, a lot of the commercial assays available have financial assistance programs. And the financial assistance program we utilize through the commercial testing that we do has been unbelievable. I have not had a patient who has had a bill. Now most of my patients do qualify for this financial assistance because the majority are Medicaid or Medicare, right, that I see. So I think that's one way, though, in terms of, because we also know there's a health disparity, a racial disparity in terms of biomarker testing, right? This is one way. The financial assistance programs are one way to improve that disparity, at least in underrepresented patients. And so all of our patients here at UIC with a diagnosis of lung cancer get comprehensive molecular testing. So usually how I approach is, when I see a patient, I talk to them about, this is a team approach. I'm here, I have the information that I'm an educator in a sense. I want to make sure that the patient has all of the tools and the knowledge necessary to make a educated decision on what the best treatment is for the patient. Obviously, I'm here to help and I make recommendations, absolutely, what I think, but at the end of the day, you can't take that autonomy away from a patient. The patient, I really feel strongly, it needs to be a patient decision on what the patient feels most comfortable with. Part of that is providing comprehensive molecular testing, and that is a complicated thing to explain to a patient. I think you really have to simplify things. At least when I talk to a patient, I kind of talk to them about the fact, I start very, very simplistically, and I ask a question, do you know what DNA is? And lots of times they'll say, yeah, I've heard of it, but I don't really know what it is, right? And so you can kind of start there with kind of describing, metaphorically is usually how I do it, putting it into something that they can understand, whether it be, I kind of talk about instruction manual sometimes for the cell, that you can get that, right? And that this testing is kind of the instruction manuals on how your cancer cells grow, right? And so sometimes we have specific changes in that instruction manual that we have targeted therapeutics for. And that's how I kind of begin the discussion about, treatment decisions for patients, at least in lung cancer. So basically, we provide them with a folder the first time I meet them. We utilize something called 4R, which is a initiative that basically it's a research initiative, honestly, where we provide kind of a framework of what are the next steps to this diagnosis. Whether that means you know PET scan, further workup, molecular testing, clinical trials, or potentially are there social economic factors that we need to take into consideration. This sheet kind of starts the conversation and allows everyone to get on the same page in terms of what the patient needs. So there's that. And then we also provide, it's from the Lung Cancer Research Foundation, the LCRF. It's a really nice graphic where, and it's a worksheet almost, and I can work through it with the patient where basically when I see a patient, I always frame it. There's 3 questions we need to answer. The first is what the cancer is. There's a nice histology sort of guideline, and that has biomarker testing in kind of integrated into it with all the different molecular results that you could have. So that's a really nice segue into biomarker testing. And then the second part is they actually have a diagram of the body and the lungs with lymph nodes and whatnot. You can actually draw the second question, which is where the cancer is for staging, right, purposes. And that's there too. So they all get that, a visual sort of thing. And then at the end, we have a patient from Go-To Lung Cancer Foundation. We have patient information, a booklet for non-small cell and small cell lung cancer. And it's really nicely divided. And I can kind of go through and say, divided by treatment modality. And I can say, hey, read this part about chemotherapy, read this part about radiation. At home they have something to access. But it's, and I tell them to bring that folder each time because we'll make adjustments to it and we can always readdress, questions that come up. In our population, we actually do have a fair amount of patients who, have autoimmune diseases that are oftentimes contraindicated for immunotherapies. I think, it's always a shared decision-making sort of process. I give them sort of the information and I give them my concerns. If I have concerns about, whether or not a patient's going to tolerate treatment, I make those concerns noted. And I certainly have patients who say, okay, I don't think the benefits outdo the risks of the treatment. But I've had others that say, hey, I want to try this and I'm okay with the risks. And I've had patients who have had terrible reactions doing, making that decision. I've had others that haven't. I think at the end of the day, that's where we make a shared decision making. And if I'm truly uncomfortable giving immunotherapy, I won't give it. But I think the patient needs to be involved in that decision. Yeah, I think the trend shift that people note in lung cancer are the non-smoking, especially in females. There's been, an increase in younger female non-smokers and the development of cancer. So, and there have been studies kind of looking at why that might be. But from environmental exposures, I'm so glad you bring that up because that's one of the things we're also working on here. Not only do I do basic science research, but we also do health disparity work and clinical research, right? And so one of the things we're starting to look at is, environmental exposures, not just, pollution and things like that, but food deserts and, exposure to crime, that's stress levels, right? All these things can be looked at and we can start to try to understand whether or not how these exposures not only may impact development of lung cancer or cancer in general and their response to treatment, but also from a biology standpoint, how is this impacting tumor biology and your immune system? Are these exposures allowing for cancer to develop? I don't know, but that's something we're going to look at, right? Well, younger patients in general that I see come in with lung cancer, um, I would say here at least, they oftentimes come in with more aggressive cancers and they progress faster. Now, that's anecdotal evidence. But, and I don't know why that is. If it's just, they're not screened and they let things go, they're younger and they don't think about things, or their doctors don't think about lung cancer and the differential, to do a early CT or whatnot to detect it early. Who knows? But I do see that. I'm most excited about some of the new immunotherapeutics that are coming out. Some of the bi-specific T cell engagers. I think if we can continue to work in that area, maybe we'll have, bi-specific NK cell inhibitors, or antibodies. And I think, starting to understand how these mechanisms of action can be applied to different realms of the immune system. I really think probably the immune system is the key, to now improving our outcomes even further. So, things like cancer vaccines, really interesting to me. Even, cellular therapies, while I don't think they're there yet in the solid space, I think understanding better the tumor immune microenvironment may lead to better cellular therapies that maybe can be employed into the tumor, into solid tumors, right? So I think I'm most excited about, immunology playing a much bigger role than it traditionally has in cancer. I hope that, in the future, especially when it comes to clinical trial design, feasibility, logistics, and then implementation, that we're not forgetting patient populations when we're developing these studies, and we're thinking about all these patient populations, and we're utilizing preclinical data that originate from these populations, so that, we're including everybody, and everybody can benefit, potentially from the next set of practice changing treatments, right?